I think a very important topic to discuss is sort of maybe heresy here, is avoiding spinal fusion for dumbbell nerve sheath tumors. And I'm glad I'm not part of the debate session where another person says the exact opposite. But thanks for giving me the opportunity to speak today, and I'll run through this and see how many advocates I can get in the audience by the end. So I want to start with the case presentation so you have a visualization of what I'm talking about. It's a 47-year-old physician, much like many of us, who has neck pain, myelopathy, and he comes to you and he has this very large dumbbell nerve sheath tumor with significant canal compromise. It's ventrally located and really, occupying 2/3 of the spinal canal. We do some preoperative x-rays and you see that he has no dynamic instability, no cervical kyphosis. And, what do we mostly do? What I learned in residency to do was this: a thorough decompression. Then we start by doing the interspinal portion, decompressing the cord, and then we go ahead and follow it out lateral, ending up with a very destabilized spine, which appropriately is fused. When I was at the NIH, I started my career and really dealt with two rare disease syndromes, multiple neoplasia syndromes called VHL and NF. Everybody in the audience knows about them. But I talked a lot about, well, you can do laminectomies and you can do intramedullary spinal cord hemangioblastomas and get fixed deformities that don't change over time. That was really important for us to be able to visualize additional tumors with MR imaging. And, we can't really extrapolate that to dumbbell schwannomas because there's one key difference. When we do a decompression and then we do a facetectomy, we destabilize the spine. This is what you get if you remove all that bone. And so the question becomes, can we do more with less bone removal and just keep the spine stable? And so I don't want to say that this is a panacea, right? And so I certainly want to talk a little bit about some preoperative considerations. Number one, this is really for the perfect dumbbell nerve sheath tumor. And I do them in nerve tumor syndromes where I know what the histologic diagnosis is. The second is that you have to prove that there's no preoperative instability at that level. And obviously a dilated neuroforamen for what I'm going to show you is going to be exceptionally nice to have, but not necessary. And lastly, I think you have to be facile with ultrasonography and have dependable intraoperative neurophysiologic monitoring to make it safe. So going back to this case that we talked about, how do I approach it? Well, I do a midline takedown. We talked about conversion rate earlier, about robotic surgeries. You heard from Rob Spinner say, well, the conversion rate's so high still, means it's not very effective. My conversion rate is 0 for this type of surgery. That's me hoping it stays that way. But, what I do is I midline takedown, keep all of the spinous process, interspinous ligaments, supraspinous ligaments, and only do a hemilaminotomy. I don't even do a full laminectomy. And then I do a little bit of a medial facetectomy and bring in the ultrasound for visualization. And that's when I start with a very systematic approach. And that is, now that we've visualized that lateral portion of the spinal canal, I decompress the intraspinal, intradural, extradural portion of the tumor, and then immediately turn to the foraminal and extraforaminal tumor. And through my approach, we can go all the way anterior to the vertebral artery, and I'll show you some pictures of this as well. So we can remove tumors all the way anterior to the vertebral artery, bring in a Doppler, microdoppler if you need to visualize or understand where it is. Then we turn our attention to the intraspinal, intradural portion. I work through the nerve root sleeve that is somewhat dilated and just do a little bit of a decompression. And it doesn't have to be much, just a little bit of internal decompression like all of you have done with any type of meningioma before resection. And then instead of opening a big longitudinal incision in the dura, all I do is remove the constriction point. This is why dumbbell schwannomas are dumbbell, because the dural tube turns into the nerve root sleeve and there's one point of constriction, and that's at that point highlighted by that blue arrow. A small incision releases the decompressed tumor and allows it to be delivered. Essentially, it's like a placental delivery. And that's essentially what we see. We see delivery of the tumor and the proximal nerve root sleeve. Proximal nerve roots, or the nerve rootlets, we transect them, and then do a dural reconstruction. So let me show you some pictures as to what that looks like for you. So in the operating room, you can see here, we haven't even done a full hemilaminectomy. It's just a small laminotomy done at the appropriate level. And you can immediately see at the very top of the foraminal of the laminotomy, you can see the dural tube, and you can see that there's some extra dural tumor there. So after decompression of that and removal, we directed our approach more anterior and stay in the foramen and remove tumor. And by doing this, we're working lateral, which is down in this photo, and you can see the distal nerve root fibers there. You can go, as I said, all the way down. After I'm done with this, I routinely bring in the microdoppler and see that there's the vertebral artery anteriorly, but you can also recognize that visually as well. After that's done, this is the important part of the presentation, is really this sort of horizontal decompression of that constriction point. Just open it a couple of millimeters. Once you do that, you put the ultrasound down and you can see that the tumor is mobile, and then we just deliver the tumor along with the nerve roots of origin. Cauterize those, and after the proximal nerve rootlets are cauterized, I push them back in the thecal sac, and then we just reconstruct the dura. Small Gore-Tex suture and some type of collagen reconstruction with some fat. I do put fat in the neuroforamen to sort of fill up that dead space so we don't have large pseudomeningocele. And that's the extent of the surgery. I put these post-operative photos in just to show you. Green arrow shows that the facet is still intact above. You can see the dura is even intact at the level, right at the level underneath the lamina there. This is the portion where the constriction point is open, but you can see that tumor is decompressed all the way anterior to the vertebral artery. And then inferiorly, you can see bone, and you can see that the dura is completely intact as well. So we've done this on over 15 patients consecutively with the intent of doing a hemilaminectomy procedure and have had 0 conversions. This is a 1-year follow-up, x-rays showing no evidence of instability, no evidence of progressive, of any deformity developing, and no evidence of recurrence. It's not a surgery that I think that can be done risk-free, obviously, and I think what is most important is to try to mitigate the risks of spinal fluid leak and pseudomeningocele formation, but that being facile with the ultrasound really enables you to build confidence to do intraspinal surgery, intradural surgery without having to open the dura and reconstruct the spine in order to do so. Thank you for your attention.